Hi there, I'm Dr. Hal Blatman. I have medical offices in Cincinnati, Ohio, and Manhattan, New York. And what I'm here to talk about is that pain is not what we were taught. People suffer in chronic pain needlessly. People go to the doctor expecting to help, and your doctor never even touches you. Well, there are real answers for real problems in chronic pain, and they're not what we were taught. Most of your pain is not coming from your disc. It's not coming from your nerves. It's not coming from inflammation as we were taught to understand it. It's coming from a lifetime of injuries to the fascia that holds you together. And you can be shown how to change that fascia with your bare hands. You can be shown how to help your body heal, and we can show you what we can do to help your body heal when your body doesn't have the tools and resources to do that. I've included some of this in an article I just wrote for New Holistic Life magazine. I encourage you to get a good read on that. I'm Dr. Hal Blatman, wishing you a very nice pain-free day.
Hello and welcome back to A Better World. This is your host Mitchell J. Rabin, and I'm very glad you're joining us again today. Today we're going to have a very interesting show. I have invited Dr. Hal Blatman on. Hal is a specialist in pain, one of those things we rarely like to talk about or deal with. Yet, he has found ways of dealing with it and understanding it that have changed the field. And he has an extraordinary background actually in pain management. He's written a book on the subject. He's traveled the world giving lectures on it. And he's here today to educate us about the nature of it. And we can learn a lot. I've been learning a lot just recently about how to understand what it is and what we can do about it. So, Hal, great to have you.
Mitch, wonderful to meet you too, and wonderful to be here. Thank you so much.
Absolutely, my pleasure. So you've been educating me about this. Now I'd love to educate our audience about another understanding of what pain is and where it comes from and what to do about it. So where do you want to start with this?
Well, let's start with some of the things that we've been taught that aren't so true, just to kind of level the field.
Yeah, please.
Because we've been taught that pain comes from inflammation. We've been taught that pain comes from nerves being pinched by discs. We've been taught that bulging discs might cause pain. All those things. And most of what we were taught about pain is not the way our biology works.
But does inflammation cause pain?
Inflammation causes a reaction in our body that makes pain worse. So yes, inflammation can cause pain. But at the same time, our bodies are designed to have inflammation for two main reasons. For repair and for defense. If we have inflammation that's causing us pain, we have a repair deficit. We have an injury big enough that we're not able to repair it, and our biology has to shift to a defense mode and make us hurt.
Oh, as a signal.
As a signal.
Okay. So you're making a point that I do know about inflammation, because we tend to just say to that inflammation, and that's not the case.
No, we don't want to.
It serves the purpose.
Right.
It serves, as you said, the repair purpose, etc. It's just that when it gets excess and is not doing the repair, then the pain signals start in.
Yeah. Ankle sprain is a good way to think about that. What are we taught to do with ankles? We're taught to ice them and wrap them and elevate
heat them,
right? Ice
and nobody knows what to do. I mean, you know, there's a bit of a toss-up about which direction to go in.
So this may help level the field. When you sprain your ankle, what does your body do with it? Does it warm it up or does it cool it down?
Heats it up.
Why does it heat it up? Couple reasons.
To bring blood to the area?
To speed up metabolism, because you warm things up, they metabolize faster.
Yes, right.
And to increase blood flow, because that's going to speed up healing. Don't you think our biology, in however many thousands of years we are old, maybe 30,000, don't you think by survival of the fittest, if that was really going on, our bodies had figured out how to heal us as best they could without the surgery in the hospitals and stuff? And so your body heats it up because that's the right thing to do. If you cool it down and you go home and put ice on it and take anti-inflammatory drugs, you've just stopped
the body's natural inflammatory process, which it needs for the healing.
And now you're not going to heal as well. You've just taken away your potential and ability to heal and decreased it. There's a wonderful study that was done several years ago giving Army recruits...
Let's appreciate the irony of that, Hal. You know, right? Exactly.
But there was a study
How did that happen?
And these army people were given meloxicam, which is an anti-inflammatory drug. And those who took the drug got back to work faster, had less pain and less swelling, but 6 months later still had unstable ankles that were uncomfortable because they never healed.
Removal of the symptoms, the pain symptoms, and no healing.
Right. So you want that part of inflammation.
Yeah.
You don't want the inflammation that causes you pain. Well, it turns out a lot of the inflammation that causes pain is a reaction in the fascia that holds us together caused by the food that we shouldn't be eating.
Okay, so the plot thickens.
The plot thickens. So aside from the injury, which we still haven't gotten to, because that's really the source of the pain, what makes those injuries light up, like you just plugged them in and set all the light bulbs up,
is the food, inflammatory
that causes an
based
inflammatory
food.
reaction in your body that you should never be eating.
And those foods are?
Bread flour, sugar, potato, fruit juice, artificial sweeteners, fake fat,
All my favorites.
all the things that are not
I'm
real
kidding.
food,
Yes, right.
right?
Right.
All the things
They're
that are not addictive,
real.
but they really nutrient. Yeah, the things that nutrient you don't do that.
Right.
Things
Nourish.
that cause the inflammation that don't nourish you as well. They may keep you from getting skinny, and they may keep you from looking like you haven't been fed. And they may make you really big, the opposite of looking like you haven't been fed.
Right.
Because those foods that we just mentioned, we call big people food. You can never be a big people eating little people food, right? You have to be, and the big people food causes inflammation that makes you hurt.
So interesting. So pain would almost be subacute had it not been for these inflammatory foods, which really light the whole thing up.
Even more so, and just to drive that point home a little bit, I have done this experiment where once a year I've gone out and skied. Now, I used to ski when I was a kid, so I've got a skill set, but I haven't done it in 20 years. And so I put skis on and think I could do what I used to do when I'm no longer strong enough to do that. But you can imagine that I pulled on my strings pretty hard, and I really worked at the skiing.
Yes.
I get out of the car after the hour drive home and, oh, you know how that feels. And you're worried about the next day. And I went home and I took my warm shower and massaged my muscles and did all the things that I woke up the next day fine. Not because I didn't have any injuries from the day before, but because my food was so clean that my body repaired those injuries under my radar and didn't even let me know that I was hurt.
That's very instructive.
And to make sure it wasn't a fluke, I've skied 3 years in a row, 1 day a year, and repeated it 3 times.
Painlessly.
Painlessly. A little bit of discomfort, but nothing like what you would expect from doing a very strenuous activity that you're foreign to because you haven't been warming up or, you know, you just go right into running a marathon.
Sure.
You should be pretty miserable the next day. Except for I didn't eat any of the food that would have inflamed my healing response, and my body just worked at healing.
So this is a slightly altered understanding of the mechanism of pain. When someone comes to you, Hal, what happens? Give an example, if you would, please, of, you know, maybe someone in particular who came and got your treatment and has been suffering for umpteen years, and then all of a sudden, voila, some changes.
So most people have an idea of where their pain comes from. They've seen other specialists who give them also those ideas. So the first thing I want to do is listen to what you've been told and what you've learned, and then also hear how your body has progressed, if it's progressed, rather than going backwards. And then the key is, I need to touch you. And you'll find, or what I find, is that many patients who have pain, the doctor has never touched them. Their diagnosis has been by X-ray, by MRI scan. Your chiropractor looks at you, he touches you, because he has to adjust you. But your diagnosis is the X-ray and what he reads on the X-ray, and then what he feels secondary. Your orthopedic surgeon doesn't really touch you. Your orthopedic surgeon and your neurologist pokes you with needles to see where you're numb, then orders an MRI scan and an X-ray and shows you where your disc is pinching on a nerve and that you need surgery, and still hasn't touched you.
As a therapist, a counselor, and acupuncturist, I'm deeply offended by this fact. It really is. It's someone who has been in touch with, no pun intended, the healing power of touch.
Right.
And knowing how children need to be touched,
Right.
or they do not get proper brain development. I mean, that's how serious and important touch is in infancy. And you can just extend that same understanding forward for the rest of one's life.
Yeah.
And oxytocin release, etc. That's how important.
One of the most bizarre things I ever heard in a pain conference was a specialist from the American Pain Society who said, we encourage physical therapists not to touch the pain patient because then the pain patient will want to come back to therapy just to be touched and they won't ever be discharged. Isn't that sick?
Profoundly.
Profoundly. Well, that's what our colleagues have been taught for all these years. And what we're trying to show is most of what we were taught about pain is not the way our biology works. And if you think about it a different way, most of the chronic pain people suffer with can actually go away. And that's what we're here to talk about.
Exactly.
An entirely different paradigm.
So go into, if you would, an example of someone that you've worked with. They come in, they've been getting standard conventional treatment, it's not working, and those are the people I imagine are coming to your doorstep.
Yes. Headaches too.
Mm-hmm.
And you know, headaches don't come from your head. And if you can touch the piece that sends off the headache and people realize, oh, that's where my headache is.
Oh, yes.
And just do this and see how they go away and they don't come back. That means changing your food, that means working on your body, that means unkinking the fascia from the injuries that you've had through your lifetime. So the most important part of what I do on the first visit is to touch.
Mm-hmm.
And you'll find that we have a skill set that we've developed, that we can also teach, that I can touch your body and by your texture, the texture of your fascia, know where your injuries are through your lifetime and know where you're tender without you having to tell me where to find it.
Well, the body is telling you.
Your
the
body
fascia
will tell
is
me.
Telling.
So I will usually introduce that by,
sure,
let's find out two things. One, let's find out what your body can teach us that you may or may not know.
Right.
And second, the most important thing, let's find out if what I feel on my side of your skin is the same thing you feel on your side of your skin without you having to tell me. Because once you know that I feel what you feel, the average chronic pain patient goes to a new doctor with one thought in mind, or I need to convince this doctor that I really have a problem, that I'm not faking, that my pain is real. That is a major concern of people with chronic pain, whether they're going to be believed.
It makes sense, because the other side of all of this is that pain is very subjective.
Right.
And it's not measurable.
Your
as
experience
such.
of it is subjective.
That's right.
Your injuries are not.
That's right.
And if I can show you them, and as I'm touching your body, you go, wow, how did you know that was tender? I didn't tell you. And you realize that I know what's going on in your body, and that changes our relationship in the first 10 minutes.
Absolutely. So you were telling me, Hal, about a woman from Long Island who recently came.
And she's had pelvic pain and headaches and pain all over her body for a long, long time.
Yes.
And she's been in therapy for a long time. And
Physical
her physical
therapy.
therapist sent her to me.
Mm-hmm.
And I find these injuries all over her body, show her where all this pain is coming from, and then I take out my tools of the trade and unlock the fascia strings that are binding her and holding her in pain. And now this is 4 weeks later, and so much of her pain is gone from that one visit. And what she's been able to do in physical therapy is remarkably different with the strength and the exercises that her therapist has her doing. Another real profound success is a woman with rheumatoid arthritis. She's in her early 30s, so she got it in her early 20s. She had too many vaccines at one time is what it's been attributed to. And by the time she gets to me with this 10-year history, her fingers are going sideways, her knuckles are swollen. She can't move this elbow. If you look at the x-ray, you almost can't see the bone. It's so faded, there's not enough calcium. And she moves it by holding her other hand. And I have to put needles and do work on her arm. And I can't move her elbow, she has to. That's her first visits with me. This woman has had platelet-rich plasma, stem cells, peptides, a very clean diet, all herbal medicines, everything we could do. And now it's 3 years
Since she
later,
started coming
since
to
she
you.
started coming.
Mm-hmm.
She can wear gloves on her hands now she hasn't been able to wear in years because her fingers aren't so swollen. She came in last time, she can actually move her elbow without the other hand holding it.
Can you see the elbow now?
We ordered x-rays. We're hoping
Okay.
we can see the elbow.
Uh-huh.
She's able to work 2 jobs, and 3 years ago she was an invalid. She couldn't work at all. And the people that the society where she belongs have decided it's better to spend several $1,000s and help her body recover and restore from this awfully devastating process and make her a productive member of their society rather than having to support her as an invalid for another 60 years, paying for her medical care and her doctors and her drugs.
And that she's depressed because she can't do anything.
And even if she lives that, and then she can't cook for herself, right. And now she's no longer crippled. She can work 2 jobs. And she had a really bad case of rheumatoid arthritis, and her biology is restoring her body and putting it back together as best as it can.
Because that's what biology does.
Exactly. And with the work that we've been able to do, she's making this happen. Well, this is true not just for headaches, but for pelvic pain, for the pain you think might be coming from your prostate. You know, if your doctor suspects a prostate infection, antibiotics might be the right thing. But 6 months of doing that, it can't be an infection. Something else is causing the pain. And nobody knows how to touch you, and nobody knows where to look for it.
Well, you're bringing up a whole interesting subject that has interested me forever because I've been studying the body in many different ways through the lens of Chinese medicine, and because I was exposed to Rolfing very early in my life, when I was a teenager, I came to appreciate the power and role of fascia. Yes. Not nearly as developed as yourself, of course, but
although Rolfing is at the core.
I had a kind of a view into the structure of the body, and not to mention body language and posture language and all of that, and what it says, speaks, and how we hold ourselves, etc.
Hi there. Using this rubber ball, you can do a lot to massage your own body. Myofascial release makes some of your pain go away. I like to use this ball against the wall, and I can use this ball to reach parts of my body my hands can't get to. My shoulder blades, the muscles over them, and my gluteals, my buttocks, are the 4 most important areas in my body for generalized aches and pains. I start this by putting my butt right on the wall. I can take the ball up here, set it on top of my shoulder, and just by leaning forward little bits at a time, I can drop that ball down and send it exactly where I want it to go. If your butt's not on the wall and you try to do that, you'll be trying to keep the ball from landing on the floor. So, secret, butt on the wall. Drop this ball down. I send it down to my bra strap. That's a good general place to go. Then stand off the wall, move your feet, maybe a foot, 1.5 feet from the wall, and then you can go up and down, covering this muscle between your shoulder blade and your spine. And I like to do this limbo. Get your belly going out, your knees going out, tilt your head back, and you can get across the upper traps just like that. And you can even just keep going like this, and that covers the muscle from your shoulder blade all the way down to about the tip of my thumb without having to go up and down and use your knees. Then I turn the ball 45 degrees, turn my body 45 degrees to the wall, and I want the ball to cover my shoulder blade from the bottom to the top. So I'm going to go against the wall. Take your arms for this position and put them across your chest and tuck them in like you're mad. If you don't have your arms tucked in, your body's going to be all over the place. If your arms are here holding on, your shoulders are going to be hiked and tense. The only way your shoulders get to relax, tuck your arms in like you're mad at somebody. Place the ball at the bottom of your shoulder blade and start doing this wiggle dance. And you'll find that you roll over this really tender rope right about there. You can stay and lean right on it if you want. You can go up and down just on it if you want, but you can also just do this because some people find leaning on it to be a little too uncomfortable, especially when you start out doing this. Now, just to see the other side, drop the ball down. You can go up and down. I like to do this limbo piece because this takes care of that cord that seems to go from your shoulder blade up your neck. And then I like to just come here and get across the top of my traps, and then 45 degrees, and do this wiggle dance to get the muscle over your shoulder blade.
Stop.
Hi there, I'm Hal Blatman, MD. Do you have pain in your lower back? Well, where does it come from? It feels like it comes from your lower back, but the only thing you can believe at the end of the day is where you can touch and feel. Where are you tender? Are you more tender here, where your lower back muscles are, right above your hip bones? Or are you more tender here, in these muscles next to your spine? Or are you more tender here, in your butt muscle? And most people with pain in their lower back, this is where the tenderness is, not here. And if that's true in you, then most of your lower back pain is not coming from your disc, your spine, or your nerves. It's coming to the injuries from your childhood and through your lifetime to your butt muscles and what holds you together in the lower part of your body.
Hi there, I'm Hal Blatman, MD, and I'd like to take just a minute and talk to you about head and neck pain. Are you able to take this muscle, just wrap your fingers around it? It's a pretty big muscle. And can you feel there's ropes and cords inside this muscle? And can you also feel that they're surprisingly tender in some places? Now, take your finger and touch the top of your collarbone. Push down and massage just the very top, and you'll feel little irregularities that are also surprisingly tender. Well, this is the injury that causes that. And the way you got that injury, you might have been an infant, and somebody picked you up by your shoulders and forgot to bring your head. Another time it happened, you were in nursery school, and somebody not happy with you came up behind you right before morning recess and shoved you to the ground, snapped your head back, and tore where the cords and strings that go through this muscle weave through the cover of this before they come down into your chest. And the results of that, through this time, here's one end of the injury, here's the other end of the injury, here's the kinks in this muscle, and here's the pain pattern of headache that causes.
Hi there, I'm Hal Blatman, MD. The muscle that controls this finger starts all the way up here. If you touch this muscle and come across it, you can make that finger move. This is tender, this is more ropey and more tender, this is less ropey and less tender, and here it's gone. All over your body you'll find this texture is not tender and this texture is. Representative of the injuries all along here. When you pull hard enough on this anchor and the strings or fascia cords slip, they twist into a knot when the cable snaps. And this knot, if big enough and bad enough, will send pain from here all the way down to your finger. Hi there. Do you wonder if you have carpal tunnel syndrome and how could you tell? Well, a lot of people, doctors, want you to go get an EMG test where needles are put in your arm and shocks are put through your nerves and muscles to measure how fast the current goes, knowing that if you have a blockage and a pinch on that nerve somewhere, that the test will be abnormal. But in actuality, that's not the best test for carpal tunnel syndrome. When I reviewed the literature a few years ago, the best test for carpal tunnel syndrome can be done at home, and it's incredibly simple. Just take your hands and drop your wrist. That makes the room in this carpal canal a little bit smaller, and if these three fingers go numb or tingle or hurt more in the next 45 to 60 seconds, it's a pretty safe bet that that wrist on your body has carpal tunnel syndrome. No needles, no fuss, no hospital, and probably the most accurate test that we have. Now, if you do have carpal tunnel syndrome, where did it come from? If you go listen to your doctor is going to tell you what he was taught or she was taught in medical school, and that is that when you do a lot of this repetitive motion with your fingers, the tendons in this canal get inflamed, that extra swelling pushes on the nerve that we're talking about, and a pushed on nerve's not a happy nerve, and you end up with the symptoms of carpal tunnel syndrome. However, when you biopsy those tendons during the carpal tunnel surgery and you send that to the lab, there's no evidence of that supposed inflammation. So maybe that theory doesn't really hold water. A much more important thought is that in order for you to do this fast work with your fingers, you have to hold your wrist still. And to hold your wrist still, you have to have a sustained contraction of this biceps muscle. If you do that, the biceps muscle ends here, but the fascia does not, and it goes all the way through to here. And this fascia tightens, and then so does the ligament. So it's not that the structures inside swell and get larger and there's no room. It's that the canal actually shrinks and gets tighter, pushing on the tendons and on the nerve. There's one more theory for carpal tunnel syndrome, and that is that many of us through our lifetime have used our hand as a hammer. And the nerve we're talking about runs right behind this ligament that crosses over your wrist. If we go look at Fred, Fred has the same ligament right across his wrist. And the nerve runs right behind this ligament down into the fingers. The surgery in carpal tunnel surgery is to make an incision through the skin, cut this ligament, sew up the skin, and send you home with a splint. So let's get back to the third mechanism I was just talking about. And that is that there can be adhesions and scar tissue between the ligament in front and the nerve that's supposed to move right behind. And if there's stickiness between the ligament and the nerve, the tendons are supposed to move through this canal when you move your fingers, and so is the nerve, because it goes all the way out to your fingertips. And if the nerve gets tugged on because it doesn't move well, a tugged on nerve is going to give you the symptoms of carpal tunnel syndrome. That surgery is much different, and that's something we do in the office, requires very little of anesthesia. We make the skin numb, we put a needle in through here, and we separate the nerve from this ligament, injecting fluid, done under ultrasound guidance, and the results are incredible. The results with carpal tunnel surgery, 50% of people get better and 50% don't, and 30% of them do not have a very good, happy ending. The surgery that we're doing with the needle, we're showing 90% improvement. 30% of those people have had to have a second one because the first one didn't do enough, and we have 0 bad results. If you're looking for help for your carpal tunnel syndrome, there's another way besides a needle, besides a knife. If you're looking for help for your carpal tunnel and your carpal tunnel syndrome, there is something much easier to do than a carpal tunnel surgery with much less rehabilitation. The hospitals right now can't really take you because of the coronavirus, and you can come and get this treatment. I'm Hal Blatman, and this is the way we treat carpal tunnel syndrome at the Blatman Health and Wellness Center.
At level 8 and 9. Up before then, I'd go, yeah, 6, it's no big deal. But when I got desperate, and I'm 79, so I'm aware that I may be totally disabled, and my independence is really important to me. And I was getting more and more restricted. I couldn't get out of my chair without thinking. I couldn't walk. I would like to walk to the bank and make my own banking, but I couldn't do it because I couldn't walk that far. It was too painful. I'm on the 3rd floor of my building. I would like to be able to walk up and down stairs, but I can't. I can if I really walk slowly, but I have to pull with my arms, and I'm afraid of falling. So these are all the things that improved. I'm getting better sleep. I can get out of my chair without thinking. That's so important. You know, what if I feel like getting an extra helping of things from the refrigerator? Nope, can't do it until maybe it gets to be more of an emergency because it hurts too much. I love exercise. I would love to exercise. I've had physical therapists tell me that I could avoid hip replacement by more exercise. I can exercise because it's so painful. I can't think or concentrate. I'm in so much. I used to be. Now I can concentrate. I did something last week that I could never have done before.
What was that?
I'm the secretary-treasurer of a tennis club, and we had a very contentious meeting with people kind of wanting one thing and other people wanted another thing, and there was a lot of arguments, and I decided to write up, I'm the secretary, so I decided to write up a complete account of what everybody said, and I could remember it. I could write up the account and think of things that might help people, things that we could do for them. And it took me about 3 hours. I could never have done this before. It just would be too exhausted. I'm also able to bend down and pick things up. I'm not perfect at it, but before, you would look at this thing that obviously needed to be picked up. I'm a good housekeeper. It would bother me to have globs of food on the floor. But I would just go, maybe I can leave that glob of food on the floor. Who cares if we get a few mice? And now I can clean it up. It may seem like a silly thing, but I do enjoy that. And also, my exercise tolerance. And you may think exercise tolerance, 1,000 push-ups, whatever. No, exercise tolerance means walking to the bank. It means being able to maybe do a few wall push-ups, maybe 2 or 3. After I did these things, a wave of tolerance, a wave of distress, pain, fatigue, it would overwhelm me, and I just had to give up on such activities, and I felt bad.
And you were saying you walked 5 blocks on the way here today?
Yes, not only did I walk, I sort of half ran part of it. I thought I was late.
And then you also were able to put your shoes on now?
Yes, I have extreme difficulty putting on shoes and socks. I kind of sit there, you know how you can get a little bit more stretch if you just kind of sit there. But let's say I'm in a hurry. It can't work. I have to take 10 minutes to put my shoes on because I'm in too much pain. And I managed to figure it out, but last week I was able to lift my leg and put my socks on. The socks are the worst. The shoes are better because they're open, but the socks are closed. It takes 2 hands for the socks, and my leg won't rise. So I can do it, but I've been saying you're about 2 months from barefoot. You know, it's so wonderful. I really, really appreciate it. The other thing is, I don't know if I mentioned I can go up and down stairs, but I used to have a lot of vertigo. I've had this all my life. I've been in pain most of my life. I had a whiplash injury. So I never thought that I would get this much improvement. I just kind of thought, I'll be happy if you get me from an 8, 9 to a 6. You know, that'll be, and you've already done it. It's. I don't think I've ever gone above a 6 this last week.
That's amazing.
It truly
you have anything
is.
you want to add? I'm so glad you're willing to share this.
Yes. I don't know if this is because of pain, but I found myself unable to concentrate. I couldn't get through this video. And I may be talking too much, but the ability to remember, marshal my thoughts, that has made a big difference. And also, I'm starting to get more energy. My husband died in 2017. I've always had very low energy. After he died, I was his major caretaker. I had no energy. I just had 0 energy. And it gradually got better. And then more recently, after COVID, I'm not able to do much exercise at all because COVID closed all the parks and the gym and everything. And as a result of constant sitting and immobility, I got even more pain. And I got more tired. So maybe tired is related to pain. So whenever I tried to do more, I would get vertigo. And if I tried to push myself, and we all should be able to push ourselves on occasion, like, you know, maybe a friend wants you to stay up late night to talk a bit or something. I couldn't do any of that. My friends invited me to be with them, and I had to say, no, I can't be with you. I can't do anything after 6 p.m. If I'm out, what if I get that vertigo and I have to go right away? It'll take me maybe half an hour to get back to my house, and I might fall down. And now I can do things like go to that meeting. That was an outdoor meeting at 7 p.m. It lasted for almost an hour and a half with everybody yelling at each other. And I was able to tolerate that without getting severely stressed. Most of the time, I had up and down surges of I'm anxious, I have to do this, and then I'm so exhausted I can't do anything. And I'm more steady.
Hi, I am Tammy Kolschmidt of Thermography for Health New York, and I'm here today with Dr. Hal Blatman.
And I'm Hal Blatman, Blatman Health and Wellness Center in Cincinnati and Blatman Integrative Healing in New York City. And we're going to talk today about prostate cancer screening and taking a look at the mouth, because what goes on in the mouth actually seeds the prostate and increases the risk and the inflammation in the prostate that does this to men.
Yes, thank you. So before I started thermography, I was actually a dental hygienist. And looking in the mouth, I would see so much inflammation, and I wanted a tool that would allow me to look at the whole body to actually see where else there's inflammation, because I know if it's in the mouth, it's somewhere else in the body.
Mm-hmm.
So that's where thermography comes in.
Because you can actually see heat, and heat reflects blood flow, inflammation, and all kinds of other. It can even reflect how hormones are not balanced in the body.
Correct.
So what can we see with the prostate in thermography?
So what I'm mostly seeing, when I do a prostate imaging, I look at the gut, right? Because that is part of the mouth, 1, 2. I also look lower at the prostate and the testicles. So we are looking for heat imbalance. And oftentimes you'll see a prostate marker, and the man might say, well, but my numbers are fine.
Right.
The thing of it is thermography picks things up often before blood tests do, before the chemistry starts to shift.
Right.
You can see a temperature change.
Which is when you want to see it before you get any of these symptoms. So you're going to pick this up before there's even an ill health effect that can be determined.
Correct. Yes, because again, with thermography, you can see things that you do not feel. And you tell me, you're the MD, but isn't it, by the time a man feels like there might be a prostate issue, isn't it a little bit already inflamed and swollen?
You know, it's like the principle of driving your car, and you like cars. When the red light goes on your dashboard, is it really a new problem? Or has it been a problem for a long time, and then all of a sudden, the straw that broke the camel's back, and now you've got a light? Well, your light in prostate is your PSA test goes high, and you've got a Gleason score and a prostate cancer. And so this looks under the hood at what might cause that prostate inflammation. And if you're a man who's already got prostatic hypertrophy, you've already got some urinary issues, we can look at that, see that, make changes in the mouth, we're going to talk about in just a minute, and reduce that inflammation in the prostate and reduce those symptoms before you get into more trouble.
Exactly. Well said. So let's go to the mouth, because I think you covered it with the prostate. When we're looking in the mouth, we're looking for hidden infections below the gum line, but it could also be an infection in a tooth or in the bone. But the key is that those hidden infections cause an inflammatory cascade. And honestly, like you said earlier, some of those bacteria can seed prostate cancers.
Yes.
So what do, you start by cleaning up the mouth, and then hopefully with whatever other treatments you're doing, you can get things under control before it turns into a really problematic disease.
And then we have ways to actually directly treat the prostate. We can inject ozonated oxygen into and around the prostate, which changes this inflammatory response. As soon as you put oxygen, the body can do a lot of healing it can't do without.
Right.
And we can also, for men, we can inject mistletoe into and around the prostate, and mistletoe can kill a cancer.
Very cool.
So the mouth ties in again, doesn't it?
Yes.
I'm Dr. Hal Blatman, Blatman Health and Wellness in Cincinnati and Blatman Integrative Healing in New York City. www.blatmanhealthandwellness.com.
Thank you. Tammy Kolschmidt, thermographyny.com.
Have a wonderful day. I'll go. Hi there. I'm Dr. Hal Blatman with offices in Cincinnati, Ohio and Manhattan, and I'm here today with Tammy Kolschmidt.
Hello. I am from Thermography for Health, New York, and Dr. Blatman and I are currently working in the same office.
There we go. And we'd like to talk to you today about breast cancer screening using medical infrared imaging for breast cancer screening, and then also looking at the mouth and the importance of looking at the mouth when you're doing breast cancer screening and considering your risk for breast cancer.
So the biggest thing that I see when we're looking at breasts is we're looking for asymmetries, temperature patterns, things that might be different from one breast to another.
Right. And we're looking at the breast with a heat camera to be able to see temperature changes and also the pattern of the blood vessels through the breast.
Correct. We want those blood vessel patterns to remain stable at all subsequent visits.
And what makes the blood vessel pattern unstable? How do we link that to high risk or low risk for cancer?
Well, the moment the blood vessels change, it's called angiogenesis, and in that instance, that is usually a sign that a tumor is definitely present.
And the blood vessels are changing to be able to deliver more blood supply and nutrition to a developing tumor.
Correct.
So we'll be able to see evidence that a tumor has a high probability of being there by looking at this rather benign test that doesn't involve any radiation, doesn't involve any squeezing or touching, and is a whole lot less uncomfortable than the alternative.
Yes, correct. And from working in the mouth, the thing that I've correlated through the years is that many people who have inflammation in their breasts also have a lot of bacteria in their mouth that we actually test by a microscope. So we can actually see in real time the amount and the types of bacteria that are present.
And you and Dr. Winnick here actually have been doing that microscope work for some time, introduced that to me, and we took that to Cincinnati. So now with our medical infrared imaging and breast cancer screening, we also are looking at the mouth under the microscope. And what are we seeing? What kind of correlation patterns, and what do we do about it?
Well, anytime there are things like spirochetes or short rods, these are all types of bacteria that we know are connected to several diseases in the body. Several types of cancers, as well as Alzheimer's, diabetes, heart disease. So when we see that, we know that there is a bioburden, there is an inflammatory response happening, even if the patient doesn't feel it.
Right.
So what we do is we approach the mouth with something we call periotherapy, which is ozone irrigation, laser treatment, deep scaling and root planing, and then several other adjustments to their home care.
And this actually decreases those biofilms and decreases those bacteria that are in the mouth. And we've been able to see in literature searches of research articles in medicine that the bacteria in the mouth actually seed the breast and increase that risk. So we're actually able to get underneath the hood and mitigate or make that risk lower, especially if we see evidence of a high-risk breast on the infrared imaging study.
Yes, I love that you said under the hood. I like cars. But it's true. There aren't many parts of your body that you can just open up and look into. That's why the mouth is so key to really, if you see inflammation in the mouth, chances are it's moving through the body. And then the beauty of thermography is that you can do the imaging and actually see it.
And you can see the evidence of it, and then you can also study down the road at some point in time and show that you've made the changes you want to make and decrease this person's risk.
Yes.
Very good. I'm Hal Blatman, Blatman Health and Wellness Center, Cincinnati and Manhattan, and
Tammy Goldschmidt, Thermography for Health, New York.
www.blatmanhealthandwellness.com and
www.thermographyny.com.
have a wonderful day.
Hi there, I'm Dr. Hal Blatman. I'm here today with,
Caitlin Ignatowski.
and we're going to talk today, continuing our discussion about detoxification, today about detox tea.
Here it is.
And this tea, you can make 2 tea bags come in this. You put it into a quart of water, and then you sip it over the next few days. There's a way to dilute it so that you can take it. And what kind of things can people expect as a benefit from this?
This is wonderful to stimulate your digestion and your digestive function,
And also to help with constipation.
constipations, and parasites.
Correct. Parasites don't like this tea and will start to exit your body. Some people have seen some ugly things come out.
We haven't verified that by our own eyes, but we do hear tall tales. So if you're interested, this detoxification tea to help you detoxify your body during this month of August and September. Good morning, everybody. I'm Dr. Hal Blatman, Medical Director at the Blatman Health and Wellness Center, based in Cincinnati, Ohio. And I'm here today with...
I'm Clint Cornell. I'm a physician assistant and health educator with the Next Direct Primary Care Network.
Also
located
in the Cincinnati area.
Yeah.
So we're going to chat today about thyroid. And one of the things that is real important is, how would you know that your thyroid is low? How would you know it's not functioning as well? How would you know that you even need to investigate this question? So what are the main things that people should know about how to find out that their thyroid is low?
Yeah, we see people come in with very vague symptoms. They can include brittle nails, dry hair, brittle hair, thinning hair, fatigue, weird skin rashes, difficulty losing weight, brain fog. Those are a few of the common symptoms that we see.
Agreed. And the things that that really just spark to thyroid, because some of those things on the list could be multitudes of issues, but the ones that really sing to the thyroid song are the fingernails chip and crack, or they're really thin and don't grow, hair gets brittle and starts to fall out, the skin is really dry, and some people say, well, my skin isn't dry. Well, do you put lotion on? Yeah, I put lotion on it every day. Well, why? Well, because it's dry, and especially the bottoms of the feet crack in the wintertime. So if those things are happening to you, your thyroid is low. Well, some people, their doctors tested them for their thyroid, and so their doctors told them they're normal. Let's talk about that controversy for just a few minutes.
Well, Dr. Blatman, one of my favorite things to treat and investigate with patients is this topic of thyroid disruption. And we know that in traditional medicine, when we go through medical school or medical training and residency and so forth, we're taught to look at a couple of lab values, and if the patient's numbers are within a certain range, then we're taught that the thyroid is working the way it's supposed to work. But the thyroid pathway is so much more complicated than just a couple of numbers on a lab test. Most people, if they've had their thyroid checked, have probably heard of a test called a TSH, and that stands for thyroid stimulating hormone. And it comes from the brain when the brain detects that there's not enough thyroid hormone in the blood. And we can get into this a little more this morning, but there's so much more going on with the thyroid pathway that when we just simply look at the TSH lab test, we are really being short-sighted, and we oftentimes miss underlying thyroid pathology.
Right. So when I do a thyroid lab, we already know that your thyroid is low. We're not doing the lab test to see if you're low. We're doing the lab test to make sure it's safe to give you thyroid hormone as an experiment. And basically, anytime your doctor prescribes a medicine for you, he's doing an experiment and you are the lab rat. And what we want to know is, if we do a thyroid test and your thyroid numbers come up really high, then it's not safe to give you thyroid medicine. Something's really wrong, and maybe we need to look down deeper and find out what else is going on, or maybe you even need an endocrinologist. But if your thyroid levels are anywhere close to the normal range, not high, middle range, low, even sometimes high middle range, we'll still give you some thyroid medicine and see what happens to you. And if your fingernails correct, your hair corrects, your skin corrects, it's not dry, you don't have to put lotion on every day anymore. If those things happen to you, then we know that your thyroid level is probably pretty close. And then we do a lab test and make sure that what we've done is safe. In that fashion, we can do responsible thyroid care. And another,
piece that people come in with is, my doctor has me on thyroid medicine. And usually it's going to be Synthroid or levothyroxine. They're the same thing. And once you're on thyroid medicine, you think everything is corrected and treated. But even if you're on thyroid medicine, if your hair, skin, and nails aren't right, thyroid medicine isn't working right. And that's more the point. And what we find is that Synthroid doesn't work that well. Sometimes it works fine, numbers are fine, skin, hair, nails are fine, but how many times do you see, Clint, people with taking Synthroid and taking thyroid medicine, and they still have an abnormal thyroid or abnormal thyroid function?
I would bet that more often than not, when a patient comes in and I see that they're on Synthroid or levothyroxine, if I make the bet that their symptoms aren't controlled on that, more often than not, I'm correct. And I think really what you're pointing out is this notion that in medicine we treat patients and symptoms, not numbers on a lab test. People aren't a number on a lab test. They're individuals with symptoms and physical exam findings and histories. And part of thyroid treatment, probably the majority of thyroid treatment, is digging into those symptoms. And as we were talking, one of the main symptoms we often see with thyroid is this idea of cold intolerance. People who are always just a little cold, they can't get warm enough. That's another one that comes to mind. But when we talk about medication, I think it's helpful to understand that the thyroid hormone really comes in several different forms. There's an inactive form that the thyroid produces. We call that T4. And it's this T4 or inactive thyroid that is the medication form. That's the levothyroxine or Synthroid. The body has to take that inactive form of thyroid and convert it to something called T3, which is the active form. It's the T3 that binds with the receptor and does the work, so to speak. And so if you aren't able to convert the T4, the inactive form, to an active form, well, your blood levels might look okay, but your symptoms aren't going to improve.
Exactly right. And so you walk around with a blood level that's relatively normal. Your doctor looks at it and says, well, your thyroid is normal. And you look at him and go, well, my skin isn't right, my nails aren't right, my hair isn't right. What is the deal? Yeah. And so we, long time ago, got into a very good habit of treating the person rather than treating the lab test. And there's other things that can throw that lab test off. Like one of the things we test often is thyroid antibodies. Yeah. You can have high levels of thyroid hormone and your immune system is taking it out of circulation and not letting it do its job. So the numbers have all kinds of reasons to not be effective. And you can't measure thyroid function by just measuring blood levels, because that doesn't tell you the whole story of what's going on. And then you mentioned temperature. Let's talk about that for a minute. That's not something you can always just correct by taking Synthroid or taking thyroid medicine, but how many people do you see whose normal so-called body temperature is 97? And weren't we taught that normal is 98.6? Can you address that?
Yeah, there's a high proportion of people who come in, and we'll catch this when we do their vital signs in the office. You'll measure a temperature and they're 96.8 or 97.4, or whatever the number might be, but it's consistently lower than that normal temperature that we're taught to look for. And one of the old-fashioned ways of diagnosing an underactive thyroid is actually to have a patient measure their basal body temperature over a period of days and track that. And we still use that technique today. So temperature is a very critical part of evaluating the thyroid.
But temperature doesn't always come up when you're taking thyroid medicine.
A lot of people with normal functioning thyroid medicine, hair, skin, nails, and so forth, and their temperature is still 97. And so what we say to these people is that 97 is never normal. It might be what you run at, but you're supposed to run at 98.6. And the reason for that is that most everything in our body happens by chemical reactions of one form or another. And if these chemical reactions were left on their own to go at their own pace, everything would happen really slowly in our body. So if our temperature is below 98.6, all the chemical reactions in our body happen slower. And the chemical reactions in our body don't happen at their own pace. They're all catalyzed by something we call enzymes. And enzymes are often vitamins that we take. And these enzymes allow chemical reactions to happen very, very quickly. But all these enzymes in our body have an optimum operating temperature, which happens to be 98.6. So if your body is running at 97, that means all of the chemical reactions in your body, including the ones that help you heal, are all running slower. So if your body's running slower and your metabolism is a little slower and you'd like to speed that up, one of the things you can do is look up Wilson's syndrome. Look it up online. Do you know much about that, Clint?
You know, Dr. Blatman, I'm familiar with it, but I'll let you elaborate more.
So Wilson's syndrome, you can look that up online, and you can download or buy and purchase the physician manual of how to treat it and the patient manual of how to treat it. And I would suggest you get the patient manual and look through that, because that will tell you what correcting this is going to take. And it usually takes a few months of cycling T3, low doses, and then raising the dose, and then bring the dose back down again, all with the purpose of correcting your body temperature and getting it back up to 98.6. We've done this a few times. It's not a comfortable process. It's not a particularly uncomfortable process. It does take a few months, and you can reset your body temperature back up to 98.6 if you're tired of running at 97 and you're willing to go through the 3 months of what it takes to reset that. All right, let's talk about some of the brilliance. Why the brilliance of the biologic design of T3 and T4. You mentioned that T4 is produced by the thyroid gland, and then the body has to convert that to T3. Well, the brilliance of that is that if the body's thyroid gland, which is right here in your neck, put out active thyroid, then all of the body parts close to here would get a lot of it, and all the body parts far away, like your fingers and your toes, they would get it last, and there might not even be any by the time the thyroid hormone gets to them, right? So the thyroid T4 gets secreted by your thyroid, circulates all over your body, and your body converts it when it gets to where it needs to be. So everything in your body gets thyroid at the same time and gets enough of it, because it converts in your big toe the same rate it converts in your fingers, converts close to your thyroid. So distance from thyroid doesn't make any difference. And that's one of the brilliant things in design about why and how the body does that. What do you most often prescribe? We've just spoken about how Synthroid doesn't work. Levothyroxine in many people just doesn't work. So what do you use instead?
Well, you know, when you brought up the Wilson's protocol, one of the reasons that I defer that over to you, I haven't used it in a long time, because it's a very difficult protocol, and it's hard on the patient, and it's a lot of work. And so we find that it's not very many folks who are willing to or able to go through that successfully. But if you have the right patient and they're motivated, you're right, that can be very effective. What we tend to look at in terms of treatment, especially our medication options, is a product that has an amount of the T4, the inactive thyroid hormone, but also one that contains the active thyroid hormone, the T3. And our preference is something called Armour Thyroid. And actually, this was a little tidbit that I picked up hanging out with you, is because the armor thyroid comes from a pig source, you get that messenger RNA that, every once in a while it might help rejuvenate the thyroid gland. So I found that was very interesting. We always went with armor as a first-line therapy because it had both inactive and active thyroid hormone, but that messenger RNA tidbit, I think, just reinforced that choice even more.
How do you know you're getting too much thyroid?
Well, again, we go back to symptoms. So if someone's starting to feel like they have tremors or shakes, or they're anxious, or their heart rate is too high, if they're feeling excessively warm, hot, those are signs that your thyroid level is too high, and we'll back off.
Agreed.
Yeah.
Agreed. And so when we give people their first doses of thyroid, we're really doing an experiment, and the person is essentially the lab test. And so if your thyroid levels are right, your hair, skin, and nails correct. If your thyroid levels are too high, then you get an uncomfortable beating in your chest. Your heart goes a little too fast. It's not dangerous. It's not something to worry about, but it's not comfortable. And as soon as you stop and bring your thyroid levels back down, it goes away just in a few hours, and you don't use that dose again. I rarely see that happen, but that's your safeguard. So that's how you can tell if your thyroid is too high. If it's too low, you're looking at your hair, skin, and nails. If you're taking thyroid medicine and you're still putting lotion on the bottoms of your feet and your heels are still cracking, your thyroid isn't up to snuff, and the medicine you're taking isn't working really well. And then there are some people, just like we were just talking about, who come in and tell me, Doc, I haven't seen you in a while, and I need to let you know about this thyroid thing. About 6 months ago, I started to feel those palpitations in my chest, so I lowered my dose, and it went away just like you said it would. And 2 months later, it came back, and I lowered my dose again. Well, I got to tell you, I haven't taken any thyroid medicine in the last 2 months, and my hair, skin, and nails are just fine. And that's what we're talking about. The messenger RNA in the pig parts that are included in the T3, T4 preparation actually helps your thyroid gland rejuvenate itself and take back over again. So that never happens with levothyroxine, but I've seen it happen a number of times with these other preparations. And there's a few, there's more than just Armour Thyroid, and they're all made basically the same way. Some of them are dairy-free, some of them are gluten-free, not all of them are everything. It depends on the fillers and how it's all put together. But you can look at and research the particulars of that. Another thing I'd like to discuss before we quit is, how often do you take the medicine? Like, there are so many people who come in and they're taking Armour Thyroid or one of the others, and they're taking it once a day. And I really need to let everybody know, this is not a once-a-day drug. This is a twice-a-day drug. And your dose should be even. What you're trying to avoid is a big peak blood level, a high peak from a dose that was taken once a day, and then you're without it when that goes away for the whole rest of the 24-hour cycle. So it should be at least taken twice a day. And if your dose is getting higher than that, you don't take 2 in the morning and 1 at night, or 1 in the morning and 2 at night. If you can't take 1.5 morning and evening, then you take 1 about every 8 hours and divide that up. And you try to even it out as much as you can. And then we have 2 more questions. One is, do you have to take it the same time every day? And do you always have to take it on an empty stomach? Because we hear both of those things a lot with thyroid preparation. What do you tell your folks?
So we tell them to try to take it as consistently as they can. And we also tell them to try to take it on an empty stomach, at least 2 hours fasting.
All right, and that's what a lot of folks say. But I have a more practical approach to it. I take my first one in the morning on an empty stomach, and I do that every morning. But I don't wake up every day at the same time, because I might take my weekday, when I'm going to the office at 6 o'clock in the morning, I'm not waking up that early on Saturday and Sunday unless there's something that I need to wake up for. So if I wake up at 8 or 9 o'clock, that's when I'm going to take my thyroid on an empty stomach. And then my next one, because I'm on a 3 times a day schedule, my next one is about 8 hours later, and sometimes I remember, and sometimes I don't. And when I don't remember, then instead of 2 o'clock in the afternoon, it turns out to be 6 o'clock at night as I'm leaving my office, and I go, oh, I forgot my thyroid today. I'll go take my second dose now. Well, it's not exactly at the 8 hours, but here's the point. Do you think the little man in your thyroid gland, who gets the message from up here that he's supposed to release the thyroid, do you think he ever looks at his watch and goes, wait on it, not yet, go? It doesn't do that. So we know that the thyroid gland pulses. We know that it secretes into bloodstream, but we don't know what makes it trigger to pulse now versus an hour from now. So as long as you get the dose in that your body needs for the day, your body can figure out the little things that are in between and different. And it's okay to miss by an hour or miss by 2 hours or even miss by 3, because what you're really trying to avoid is taking 2 of them at the same time and having a peak blood level that shuts down your biofeedback mechanisms that you need. So you don't overpower your biology. And that's why you divide it and do it in divided doses. Yeah, you can make it for a while taking it once a day, but usually in about a year, sometimes 2 years, sometimes even way sooner, depending on how big that dose is, your thyroid is not going to work. And here you are taking the medicine, your blood levels are maybe sky high because now it depends when you test, and you still have thyroid symptoms because that once a day doesn't correct you. So let's talk about empty stomach versus full stomach, and then let's talk about when to test. So I take the first one on an empty stomach because that's first thing in the morning. But my other ones, not necessarily so. And if you forget to take the one before dinner, then take it after dinner because you still need it. And your body, it will absorb more slowly. You might not absorb quite as much, but you're still getting it into your body, and your body will figure out some of the differences. And it's not worth making you crazy to make sure you go 2 hours before, 1 hour after, whatever that number is. That's enough to make you goofy during the daytime. So I try to tell people, just, you'll know you're doing right by your hair, skin, and nails. And as long as you're close enough and have good enough thyroid, your body will give you the right answers. So one more, let's talk about when to test. So you're at your doctor's office and your doctor says, let's test your thyroid. Is that ever the right answer? And I'm going to tell you no. So when do you send your patients for test?
So we usually test first thing in the morning, and after a fast of at least.
Well, we don't do it that way. We do the test midway between doses. If you're supposed to be taking it 3 times a day, that's roughly 8 hours, then we want to test you 4 hours after your empty stomach dose. If you're taking it every 12 hours or supposed to be taking it twice a day, then we want to test you at 6 hours after your morning dose. If you test in the morning before your dose, your levels are going to be really low because your last pill was 12 hours ago. If you test right after your morning dose, your levels are going to be sky high. So that's not the right answer either. You want to know where you are midway through the day. You don't want the peak. You don't want the trough. You want to know where you are in the middle. And that is midway between your doses. If you're taking it every 8 hours, it's at 4. If you're taking it every 12 hours, it's at 6. That gives you a level that you can understand. And if you are taking my thyroid medicine and your family doctor orders a thyroid test and you do it 2 hours after you take your thyroid medicine, your levels are going to be really too high, and your doctor isn't going to give you the right answer. He's going to lower your medicine. And that's not the right answer either. So those are the things that are critical. Don't take it all at once, and make sure your lab test is timed. All right.
Okay, Dr. Blatman, if you could pick a number between 1 and 3, we're going to be awarding someone lifted infused tea samplers.
Let's pick 3.
Sylvia, congratulations. This is Taslima. She's the creator of Lifted Teas, and you can find her products at symbol Lifted LFTD Infused Tea, and that's on Instagram and Facebook. So Sylvia, you're the winner today. Is she
All right.
there?
She's here. She's here. She's muted. Let me see. I can unmute her. Does all this have an effect on your liver and your white blood cells being low? I don't know. I've not heard an effect on liver and white blood cells being low. I'd be looking for something other than thyroid. Have you seen thyroid issues? Low thyroid affecting white blood cells and liver?
No, there's no correlation that I'm aware of. Thyroid really is so much to do about metabolic rate and energy production in the cell. Not much correlation with white blood cell count.
But Sylvia, your issues of dry, itchy skin, cold off and on, and fatigue could certainly be related to thyroid, and once a day is not the right answer. And so now you can correct that. So take it twice a day, and if you need a bigger dose, then if you can't split it in half, then you take it 3 times a day. All right. I'm really glad we did thyroid.
Okay.
That's all.
Sylvia, you may reach out to me at Dr. Tranquility, Lydia on Instagram, or Taz directly at Lifted Teas, and you will get your sampler at Lifted LFTD Infused Tea, and we will make sure you get your sampler. Okay.
All right. Well, thanks, everybody. Have a wonderful day. We'll pick a topic for next week, and we'll see you next Saturday morning. Bye now.
I'd like to discuss for a couple minutes why carpal tunnel syndrome happens. We were taught when we went to medical school, and with a predominant view today, is that when you do a lot of this kind of motion with your fingers, the tendons that go through your wrist canal or carpal canal have to move. They get inflamed from all that activity, and that pushes on a nerve that runs right behind this ligament that connects these 2 sides of your wrist. And the surgery is to make an incision through this wrist and then through that ligament, let that ligament separate, sew up the skin, and let you go home and figure it out. That relieves pressure of the structures that go through this canal. And if we send the cover of those tendons off to the pathology lab, there's no evidence of that supposed inflammation. So maybe that theory doesn't hold any wash. There's 2 others that I'd like to talk about. One is, in order for your fingers to do this really fast, you have to hold your wrist really still. And to hold your wrist really still, that requires a sustained contraction of your biceps muscle. And while the biceps muscle ends here at your elbow, the fascia that goes through this muscle and holds it together continues all the way to your palm and fingertips. And as this muscle stays contracted, the fascia tightens. And then the fascia in your forearm tightens. And then this ligament actually tightens, and the canal through your wrist gets smaller. So it's not that the structures inside the canal swell up, it's that the canal actually shrinks. And the articles that describe that were written in the osteopathic literature back in the mid-1990s, and they talk about a set of stretching exercises that we teach still today, where you stretch the forearm biceps, you stretch the forearm, that we still teach today, where you stretch the biceps, the forearm, the transverse carpal ligament, and there's a set of stretching exercises that we describe in my book, Winner's Guide to Pain Relief, that talks about how to relieve your symptoms of carpal tunnel syndrome, thinking that the cause is from all of this fascia tightening and this shrinking. The cause is all of this fascia tightening and the canal actually shrinking. And in actuality, the case reports show that not only do carpal tunnel symptoms get better, but a positive EMG test, which was the gold standard
and still is considered the gold standard for carpal tunnel screening, that test can go from positive to negative just with this set of stretches. We've described them very well in my book. Another theory for carpal tunnel syndrome is that many of us through our lifetimes have used our hand as a hammer. Hand's not meant to be used as a hammer, and that causes injury to the carpal canal, especially adhesions or stickiness between the ligament that covers and the nerve that goes right behind it. And if there's any adhesions or stickiness, when you open and close your fingers, the tendons obviously have to move, but the nerve has to move through this canal also, because the nerves go all the way to the fingertips. And if the nerve is stuck on the back of that ligament, when you open and close your hand, it doesn't move well. And if you tug on a nerve every time you open and close your hand, that nerve gets very unhappy and you get the symptoms of carpal tunnel syndrome. The fix for that is we do a needle surgery and hydrodissect. That means we put a needle through here and use fluid to separate the nerve from the ligament so that it can flow freely in this canal. No incision, no sutures, very uncomplicated recovery afterwards. 30% of the cases that we've done have required a second procedure, but we have 90% good results and 0 bad results. Whereas if you go for carpal tunnel surgery with the traditional incision across your wrist, that has 50% good results, 50% not good results, and 30% of them can be disastrous results where you have chronic issues perhaps for the rest of your life. There are different ways to handle carpal tunnel syndrome. We hope we've helped you. This is our IV therapy room. We do various different IV nutrients and various intravenous treatments to help people recover from Lyme disease, help people recover from chronic fatigue, and many other issues. Do you know a musician who is suffering from pain that could end their career? Perhaps their situation has become such that they are now trying to avoid surgery that could also be career-ending. Finger pain from joints and muscles, cramps in forearms, neck and shoulder pain, headaches, wrist pain and arthritis, drummers with shoulder pain, thigh and calf pain and cramping. At the Blatman Health and Wellness Center, we have experience in treating musician injuries and pain, saving careers of instrumentalists playing strings, keyboard, percussion, and more. If you know a musician who needs help to continue in the life they love, share this post and help them get the help they need.
Our next speaker is a nationally recognized specialist in treating myofascial pain. He's board certified in integrative and holistic medicine on the topic of exosomes and chronic myofascial pain, rebooting the body's self-healing mechanism. My great pleasure to introduce to you Dr. Hal Blatman. Welcome.
Good morning. Thank you, Alex. And welcome everyone else. Dr. Hal Blatman, Medical Director of the Blatman Health and Wellness Center in Cincinnati, Ohio is our base. I have an office in Manhattan and also in Seattle. I'm going to go and share screen. Share. Slide. There we go. I'm going to speak today about exosomes, chronic myofascial pain, rebooting the body's self-healing mechanisms, and specifically talk a little bit about where does lower back pain come from, how to make it go away, and show you some exciting things we've learned about scoliosis. Exosomes are tiny vesicles full of growth stimulators and growth factors given off by stressed out stem cells. They're harvested from stem cells and they can be used to help heal, repair, and grow new tissue. You can apply them topically, you can inject them into fascia, into joints, and you can use them intravenously and also into spinal cord. Let's talk what is chronic pain. Everyone agrees that it starts with an acute injury, but the world is taught after that acute injury causes acute pain that if that pain stays longer than 3 to 6 months, it magically transitions to chronic pain, in which case we have no hope to make it go away, and what we have to do is stop the signal. So we kill the nerves, we use epidural steroids, we make the nervous system not work using various medications and TENS units. Fortunately, that's not the way our biology really works. It's just the way medical doctors were taught. Our reality is that acute pain does come from an injury, but the reality is that our body will continue, or our brain will continue to experience some evolution of that pain until we heal from the injury that caused it. And it doesn't matter how many years it is, doesn't matter how long we've had it, doesn't matter what part of our body it's in, most chronic pain can be made to go away. There's almost no such thing as intractable pain. Granted, it happens. There are people who suffer. This doesn't work 100% of the time. But there's so many people who suffer that don't need to, believing that their pain can't go away. And when you heal those injuries, you can make most of this pain go away. So, where does pain come from then? How do you figure it out? And then how do you make it go away? Well, you learned from this seminar and all these wonderful speakers that a lot of medicine is not what we were taught. Well, indeed, most of pain is also not what we were taught. So, I've coined 5 rules of how do you figure out where your pain comes from. Rule number 1, you can't believe the pain comes from where you feel it. Your headache does not come from your head, not from your blood vessels, not from your nerves, not the way we were taught to believe. Your knee pain doesn't come from your knee. Just ask the people that you know who've had their knee replaced, and how many of them does their knee still hurt? And the pain in your left arm could be your heart attack. You don't really know. Rule number 2, you can't believe what you think the pain feels like. We were taught to really ask questions about where does it burn, where does it tingle, where does it ache, all those varying nuances of how you perceive the pain. And truth be told, it doesn't really matter. None of those differences are diagnostic. Burning doesn't necessarily mean anything different than aching or stabbing. It all comes from the same stuff, or most of it does. It's not diagnostic. The location of where you feel the symptoms is incredibly important, but what they feel like is a backseat. Rule number 3, what can you believe? What you can believe is where your fascia is tied in a knot, where those ropey bands of muscle are really tender. Those are the kinks in your fascia that generate a lot of this pain. And then if you trace that rope out to where it ends and attaches and links to your skeleton, you'll feel the injury of how did it happen. Rule number 4, the places as we examine you together, you and I, where you're most specifically tender, represent the injuries through your lifetime that cause most of the pain that you came to see me for. And rule number 5, about 90% of the time, as quickly as we can unkink the fascia that holds you together, and as quickly as we can reinforce and help you heal the injuries that happened through your lifetime, the pain you thought you had will go away. And so often, it's not a whole lot more complicated than that, with the exception of, as everyone else has said this morning, your food needs to change. So, fascia has many forms. It can be sheets, it can be strings, it can be a ligament, it can be the cover over your brain. And Tom Myers discovered by fascia-sparing dissection that it occurs in lines through the body. You can trace it from one place to the next. Here is the superficial back line of human fascia. Take a look at this video. It starts looking at the toe or the plantar fascia where foot pain may come from, the heel, the gastroc tendons, the gastroc muscles, the heel cord. Look where the hamstring and the gastrocs attach. They only tack into the back of your leg. They really attach to each other. If your hamstrings are attached, you're coordinated differently than if they're separate. So how you're put together depends on what you can do with your body, or helps determine it. This is the lumbar fascia coming up to the muscles that go up your spine, and shortly you're going to see here is your neck, and then the yellow on the top is the galea that goes up over your head all the way to your forehead. You are one string, goes down from your forehead all the way down to underneath the balls of your feet. In a similar fashion, you have deep and shallow lines up the front, up the sides, spiral lines across your middle. We'll talk about that in a few minutes when we talk about scoliosis. So, in order to illustrate the point, let's feel your neck. There's a muscle right here where this green arrow is, blue arrow. right here. You can put your hands on that. You can feel that it's really tight. You can feel a rope through that muscle. And you can feel at different places it has different levels of tenderness. That texture is what you need to know to be able to touch someone and tell them where their pain is by what they feel like in your exam. And then feel down here, right on the top of your collarbone, where this muscle attaches. And there'll be some places that are really tender. That's the injury that causes this knot. How did you get it? Maybe you were in nursery school and you walked in the morning and Sally, you just irked her just by walking in because your lunchbox was the same color as hers. And she came up behind you right before morning recess and pushed the back of your shoulder blades and tore this muscle, and you wear it in this knot, which may be causing you migraine headaches for the rest of your life. You grasp and pinch the muscle just like that. You feel it just like this, and you can feel those ropes and knots too. And if you hold on to them a little longer, you'll feel the pain go right to your eye. And when you let go, you'll find your neck moves better and your head moves better, and you've just learned how to help make this go away. And so the X's represent the kinks, the red speckles are where you have the pain pattern however you perceive it. And here's one end of the injury, here's the other end of the injury. So, if we look at lower back pain, we're taught that our pain comes from these nerves. We're taught that we injure this disc. Well, how many people do you know have had that surgery and are better or still hurt? So, if we look at these treasure maps, where is the kink, where does the pain come from? These are by Janet Travell and David Simons. Here are the ones for lower back pain. Most of the pain that you think is in your lower back comes from this tender area in your glutes. And where are the injuries? You can feel to where the rope ends, on the top part and the bottom part. Those are the injuries where you're most tender from this lower back pain. And the fascia strings go all the way down your leg, and that's most of the reason for the transmission of the pain. And the thing you felt give wasn't your disc, wasn't your lower back. It was the tendons that hold your butt together. And where did you first injure them? When you were a child, jumping out of trees, jumping down the steps. And you were the kid that led the other kids, followed the other kids, or watched the other kids jump off the roof. So, for treatment, you make these kinks and trigger points go away. You restore and strengthen how you anchor and hold together. And then you also need to reduce the food and toxicology-based inflammatory pain. So we on our website, www.blatmanhealthandwellness.com, have a do not eat list that you can get by signing up. That do not eat list gives you the inflammatory food list for your biology. I don't believe there's one diet that's appropriate for anybody. We're all a little bit different. But I do strongly believe there's a do not eat list for our species. We need to stay away from poison or things that aren't good for our biology. So, you know that this is tender because of an injury. You now know some understanding of the tenderness by your hips and what that means from jumping off the roof. But your body has no idea that it didn't heal you when you did that and created those injuries. And we've injured these areas many, many times in our lifetime. This wasn't just from nursery school. This was from a car accident and from standing on your head and from the cheerleading accidents and God knows what else. And every time you injure, your body runs a repair program to fix you, but at the end of the day, your body's done an incomplete job and it has no idea. So to turn on your healing program, we have to re-injure you. We do that by poking you discreetly with a needle. And then we need to put magic into the needle so your body heals faster and stronger than it could on its own. Well, if you remember, you skin your knee, you bleed, you make a scab, and 4 weeks later, the scab falls off and you have new skin. Well, this isn't any different. We take blood out of your arm, concentrate the parts that would make that scab, add exosomes, maybe add stem cells, put that into these areas as we create this wound. And in 4 weeks, 8 weeks, and 12 weeks, as the scab falls out and as your tissue becomes stronger because of what we put in, you heal and you grow a new tendon, whether it's for your hip, whether it's for your rotator cuff, You don't really need to have the surgeries we were taught that we needed to do. So here's an example. This woman has head and neck pain, bad hip and lower back pain, and her weaknesses are where her tendons hook up and where her fascia hooks up for her thigh, for her glutes, for her neck. And so on one day we go and we do a needle surgery to repair all these areas, and a month later, look how much better she is. And 2 months later, even better than that. You are not destined to have pain just because you have old injuries that you don't know how to find and your body doesn't know how to repair. Let's talk about scoliosis. Scoliosis occurs, in my belief and my understanding, when the fascia strings that you just saw evidence of by that dissection video, the child grows and the fascia strings either don't grow fast enough or they contract pathologically, pretty much like Dupuytren's contracture when it closes the hand. And when that happens, the patient or the child can't grow vertically, so they grow in the path of least resistance, which is not an S-curve, it's a spiral. It looks like an S-curve because it's a two-dimensional X-ray, but there's a rib deformity that goes with this, and the spinal bones get deformed by the time you're 17 years old. So if we're going to help you reverse it, we need to do it while you're a lot younger. And the reason surgeries are done and rods are put into children is so that their spine doesn't become so deformed that it compromises their lung function and they can't breathe. So, this is a child. He was 13 years old. He was noted to have scoliosis by the school nurse, confirmed by the family doctor. No forward-up plans were given. 6 months later, just about a year ago, the son told the mother that the ribs were sticking out. She didn't pay attention. And last December, the school nurse noted scoliosis again, and this time the orthopedic surgeon took an x-ray, and the x-ray showed this curve that you see on the left-hand side. The father knew me, sent mom and child on an airplane to visit us, and we released the fascia that binds the child, and his second x-ray is a whole lot different. The curves changed on the top from 43 to 35, and on the bottom from 45 to 28. We're fascinated by this. It's preliminary, but it gives us a different understanding of how do we change scoliosis and prevent the surgeries that traumatize so many children. So, exosomes and stem cells can also be administered intravenously. You can accelerate healing from surgery. You can rejuvenate your body. There's all kinds of hope for many different chronic diseases. Here's arthritis. So this is a year stem cell injections into the knee. Not my data, but data presented at a conference. This is how much growth happened in a year from one injection of stem cells into the joint for this patient. Also, the immune system can be changed. You can help settle down the immune system in rheumatoid arthritis. These are the after pictures. This woman had rheumatoid arthritis for 10 years before we saw her. Her knuckles are a whole lot less swollen than they used to be. She can wear gloves she hasn't been able to wear in years. I wrote a book several years ago to help teach these concepts to people, to teach you that your pain comes from fascia and to teach you what you can do about it. The book is called Winner's Guide to Pain Relief, available on our website, www.blatmanhealthandwellness.com. It gives you a self-help book where you can learn how to take a rubber ball, find these knots and kinks in your fascia, and massage them out yourself. And when you look on our website, not only can you order the book, but you can sign up for our community talks. Saturday morning at 9:30. I'm going to go through topics in a similar fashion to this and help teach you more about your body. Here's pictures from the book showing you how to use that rubber ball on that muscle, that knot in your butt that I showed you on a previous slide. You rub that knot out well enough, you can help make a lot of that pain go away. Unkink the knots, smooth out the fascia, and then learn how to unglue the fascia, learn how to repair the fascia so it doesn't come back. So, headache, lower back pain, pelvic pain. Pelvic pain isn't any different. Everybody thinks it's the pudendal nerve and pudendal neuralgia and psychosocial emotional trauma, which certainly is part of the deal. But you have fascia injuries that need to be repaired. They can be found, they can be repaired.
Pelvic pain is pretty much a migraine. Instead of it being in your head, it's in your pelvis. Like lower back pain can be a migraine in your lower back. All these pains are caused so much by the same thing. And then to give you insight into scoliosis, what really causes it and what are the possibilities to help a child grow up without that curve. Want more information? We have a newsletter that comes out you can sign up for, www.blatmanhealthandwellness.com. I'm also present in New York. Our office once a month is 321A West 24th Street, on the west side, 8th and 24th. I also have a presence in Seattle where I'm part of the faculty at Bastyr University, a naturopathic four-year medical school. You can reach us at 844-282-8900. Thank you very much. I have some time perhaps for questions.
Great presentation, Dr. Blatman. Thank you so much. Anyone has specific questions? We have a minute or so here. But you've seen people resolve problems that they couldn't resolve before: back pain, elbow, tennis elbow, neck pain,
All of these things. And we do this for weekend warriors. We do it for the young. We do it for the old. We see children in the office, and we have a lot of experience with professional athletes. Things that have a lot of difficulty healing. You need to get back on the field to play. College athletes, high school athletes. There's so much we can do to accelerate healing and get ourselves back in the game.
Michael wanted to know, to what degree is moderate scoliosis reversible to normal?
Once your spine has deformed, your spine bones actually will start to look like a double trapezoid deformity, like a spiral staircase. Once that happens, it's really hard to undo. If we get you before that happens, oh, possibilities are pretty strong. So we like to see you between 11 and 14 years of age. We can always help with the pain, can always help with the discomfort. Even if you're 40, 50, and 60 years old, it's rare that our work won't be helpful.
Very great. Well, thank you so much, Dr. Blatman. I appreciate your unique approach and your passion for your work. We appreciate you being here. Thank you.
Thanks, Alex, and thanks everyone for being to listen.
Great.